Hi, my name is Amanda Whittle, and today I will be presenting on kyphoscoliosis. Kyphoscoliosis is a combination of two different thoracic deformities. First, we have kyphosis, which is a posterior curvature of the spine, also known as humpback or hunchback. And second, we have scoliosis, which is when the spine is curved to one side, typically appearing as an S or C shape, and it's most obvious in the anterior-posterior plane. When these two disorders appear together as kyphoscoliosis, the deformity of the thorax can compress the lungs and restrict alveolar expansion, which can lead to alveolar hypoventilation and atelectasis. Severe kyphoscoliosis causes a chronic restrictive lung disorder that makes it more difficult to clear airway secretions. Anatomic alterations of the lungs, you're going to see lung restriction and compression as a result of the thoracic deformity, a mediastinal shift, mucus accumulation throughout the tracheobronchial tree, and atelectasis. Kyphoscoliosis affects approximately 1% to 2% of people in the United States, mostly young children who are going through a growth spurt. The precise reason for the combined disorder is often unclear, but it is a result of the compensatory effects of the spine in response to the primary lateral curve in scoliosis. There are different types of scoliosis. First, we have congenital scoliosis, which results from a malformation of the spine or fused ribs during fetal development. Second, we have neuromuscular scoliosis, which is caused by poor muscle control, muscle weakness, or paralysis because of diseases such as cerebral palsy, muscular dystrophy, spina bifida, or poliomyelitis. And then third, we have idiopathic scoliosis. It's an unknown cause that appears in a previously straight spine. About 80 to 85% of kyphoscoliosis cases are referred to as idiopathic kyphoscoliosis. And there are three types. First is infantile scoliosis, which is when the curvature develops within the first 3 years of life. Second is juvenile scoliosis, which is when the curvature develops at 4 years of age to the onset of adolescence. And third is adolescent scoliosis, which is when the curvature develops after the age of 10 years and is the most common. There are several different risk factors for scoliosis. First, we have gender. Girls are more likely to develop a curvature of the spine than boys. Age. The younger the child is when diagnosis is made, the greater change of curve progression. The angle of the curve. The greater the initial curvature, the greater the risk that progression will worsen. Location. Curves in the middle or lower spine are less likely to progress than those in the upper spine. Height. Taller people have a greater chance of curve progression. And spinal problems at birth. Congenital scoliosis has a greater risk for worsening of the curve with aging. The diagnosis of scoliosis is diagnosed by the patient's medical history, physical examination, X-ray evaluation, and thoracic spine curve measurements. It's commonly defined by the following factors. Shape, we have non-structural, which is a C or S-shaped, or structural, which is twisting of the spine, and it appears in 3 dimensions. Then we have location. You can have it in the thoracic, which is the upper back, lumbar, which is the lower back, or both. Then we have direction. The spine can bend either to the left or to the right. And then the angle, a curvature greater than 10 degrees, and it's expressed by the Cobb angle, which is calculated from a radiograph. The causes of kyphosis, we have degenerative diseases of the spine, such as arthritis or disc degeneration, fractures caused by osteoporosis, slipping of one vertebrae forward on another, endocrine diseases, connective tissue disorders, infections such as TB, muscular dystrophy, Paget disease, polio, spina bifida, tumors, and Scheuermann disease. Cardiopulmonary clinical manifestations. In the laboratory findings for severe and or late-stage kyphoscoliosis, if the patient is chronically hypoxemic, you're going to see an increased hematocrit and hemoglobin. hypochloremia, and hypernatremia. The radiologic findings of a chest radiograph, you can see a thoracic deformity, a mediastinal shift, increased lung opacity, atelectasis in areas of compressed lungs, and an enlarged heart, which is also known as cor pulmonale. In a pulmonary function test, some of the findings for moderate to severe kyphoscoliosis, for the forced expiratory volume and flow rate findings, we're going to see a decrease in the forced vital capacity, a normal or decreased forced expiratory volume in a specific time, a normal or increased FEV1, FVC ratio, a normal or decreased forced expiratory flow between 25% and 75% of forced vital capacity. We're going to see a normal or decreased forced expiratory flow at 50% of forced vital capacity, a normal or decreased forced expiratory flow between 200 and 1200 milliliters of exhaled volume during a forced vital capacity. We're going to see a normal or decreased peak expiratory flow rate and a normal or decreased maximal voluntary ventilation. For the lung volume and capacity findings, we're going to see a normal or decreased vital capacity, a decrease in inspiratory reserve volume, a decrease in expiratory reserve volume, a decrease in residual volume, a decrease in vital capacity, a decrease in inspiratory capacity, a decrease in functional residual volume, a decrease in total lung capacity, and a normal RV-TLC ratio. For your arterial blood gas in moderate kyphoscoliosis, which is acute alveolar hyperventilation with hypoxemia, also known as acute respiratory alkalosis, you're going to see an increase in the pH, a decrease in the PaCO2, a decrease but normal range in the bicarb, a decrease in the PaO2, and a decrease in the SaO2 or SpO2. For severe kyphoscoliosis, which is chronic ventilatory failure with hypoxemia, also known as compensated respiratory acidosis, we're going to see a normal pH, an increase in the PaCO2, a significantly higher bicarb, a decrease in the PaO2, and a decrease in the SaO2 or SpO2. General management of scoliosis, you have conservative treatment, such as observation, which is recommended in patients with a spine curvature of less than 20 degrees, braces, which are recommended in patients with a spine curvature more than 25 degrees, and it's the first line of defense for idiopathic scoliosis to prevent the curve progression, but it's not effective in congenital or neuromuscular scoliosis. Then we can look into surgery, such as spinal fusion, rod instrumentation, or the Cottrell-Dubocet instrumentation. Other approaches include electrical stimulation of muscles, chiropractic manipulation, and exercise. Respiratory care treatment protocol, we have the oxygen therapy protocol, which treats hypoxemia associated with kyphoscoliosis and decreases the work of breathing and myocardial work. This can include nasal cannula, high-flow nasal cannula, and a non-rebreathing mask. Airway clearance therapy protocol, which is used to mobilize excessive bronchial secretions, and it can include CPT, coughing techniques, autogenic drainage, PEP, exercise, and mobilization. Then we have lung expansion therapy protocol, which is used to treat and avoid atelectasis, pneumonia, and ventilatory failure. And this can include devices such as the IS, the CPAP, PEP, IPPB, and high-flow nasal cannula. Lastly, we have mechanical ventilation protocol, which is used to treat hypoxemia and acute ventilatory failure superimposed on chronic ventilatory failure. This can include non-invasive ventilation or invasive ventilation, such as endotracheal or tracheostomy tube. And this concludes my presentation on kyphoscoliosis.